He's a 14-year-old male, fell yesterday playing basketball, and since that time he's had really inability to walk and a lot of pain in the knee. He said he was able to push his finger deep down over here over the proximal patella tendon. It seems like I could feel a tendon, but it definitely feels a little softer than the other side. He cannot lift his leg extended off the table, which is concerning for an extensor tendon injury. There's no pain up here in the quad tendon, right? So we're going to really focus on the patella tendon. He's got a lot of moderate-ish to pretty large amount of swelling here in the lateral leg. So given the fact he couldn't lift an extended knee off the exam table, I was obviously worried about his extensor mechanism. Here the patella tendon looks intact and long access. It didn't feel disrupted also on exam, but for sure you want to get some sort of image to confirm that. An ultrasound does clearly show a intact patella tendon. He does have this ovoid dark ano area just under the distal patella tendon. I think that's a deep infrapatellar bursitis that he has as well. It could be the fat pad. I'm just not perhaps seeing some of the septi or hyperechoic septi within it, but I think it is a deep infrapatellar bursitis. Here we're looking at the patella tendon in short access. Again, it looks intact, no significant tendinosis. You can still also see that kind of dark ovoid structure underneath the patella tendon laterally, and again, I think that is the deep infrapatellar bursitis, but again, an intact patella tendon. So other tendon you want to examine is the quad tendon. Again, this shows an intact tendon, has that trilaminar type of appearance, even though here it looks like you're only seeing 2 layers, but I don't think there's any disruption of the tendon. Here you can see his growth plate. There's no effusion in the knee joint, which is encouraging. And now we're going to look at the quad tendon in short access. Not as discrete borders as the patella tendon, but you could make out this trilaminar appearance in the short access view as well, the quad tendon. So the extensor mechanism in the knee looked okay, but he was complaining of some pain over the kind of the mid aspect of the anterior lateral leg, and he does have pretty significant swelling. So I just want to ultrasound the musculature in the anterior compartment. He has this kind of dark, ovoid, irregular structure, kind of like a butterfly wing type shape in the tibialis anterior muscle, and I think this is a hematoma within the muscle. So I think he acutely tore the muscle. I just wanted to make sure I wasn't looking at an intramuscular vein or artery, and so I put some color Doppler on, and I did not see any flow. This was an area where he was focally tender, but he was a very vague historian. He couldn't really pinpoint where his pain was. So this to me seemed like the most tender part of his exam. And now we're going to look at the tibialis anterior muscle in long access. Much harder to really see the borders of this hematoma, but you can see this dark anechoic signal going through the musculature consistent with a muscle tear and hematoma. However, this muscle tear was just part of his pain. He had a lot of pain in the knee. So we kept him non-weight bearing in crutches, and we got an MRI of his knee, which actually shows a Salter-Harris 2 fracture, thankfully non-displaced, of the posterior aspect of the tibia, which you can see here. Here in axial sequence, you can see how this fracture really goes through almost the whole width of the tibia on its posterior aspect. Again, communicating with the growth plate, making it a Salter-Harris 2 fracture. Here we're going to look at some coronal MRIs. Fat saturated shows a lot of signal, mainly below the growth plate, but also some focal signal above the growth plate laterally. But this fracture is most clearly depicted on the sagittal views. Here we're looking at the MRI of the tib fib. You can see a significant amount of signal within the tibialis anterior muscle and dark signal towards the posterior aspect of the muscle, consistent with this hematoma, which was clearly visible on ultrasound. So some of the take-home points in this case, since I did not expect to see a Salter-Harris 2 fracture, if the diagnosis is not clear initially, as in this patient who also had knee pain in addition to this leg pain, certainly keep the patient immobilized and non-weight bearing until you get further imaging and you can further clarify the diagnosis. Also, this patient, the Salter-Harris 2 fracture was not seen on x-rays initially, both in urgent care and at the office when I saw him initially. And therefore, if you suspect a fracture, you need to further image with either an MRI or a CT scan. And this patient was also quite vague and stoic, so even though he may seem like things are okay, always assume the worst and order the appropriate tests. Here we're going to go over just a side-to-side comparison of the MRI with the ultrasound. Here you can see this black anechoic signal within the tibialis anterior muscle and ultrasound on the left, and you can correlate that with the low signal density in the tibialis anterior muscle on the axial MRI on the right. And another thought regarding this case is this patient had difficulty raising an extended leg off the exam table. Again, this would make you think of an extensor tendon injury, which he did not have. However, perhaps this muscle tear in the tibialis anterior muscle was why he was having pain and difficulty raising an extended leg off the exam table, as perhaps he tried to keep the foot somewhat dorsiflex, and this would engage the tibialis anterior muscle, which would subsequently cause pain. Certainly the fraction of knee can cause pain when trying to raise his leg extended off the table. However, I don't think that would explain entirely his inability to raise his leg off the table while the knee is extended. Here we're going to run through some of the anatomy of this tear of the tibialis anterior muscle. Here you can see the anterior and lateral compartments, specifically the tibialis anterior and extensor hallucis longus and extensor digitorum longus, as well as the peroneus longus muscle. You can appreciate the superficial peroneal nerve coming underneath the peroneus longus muscle as well. And here's this hematoma within the mid-substance of the tibialis anterior muscle as a result of this injury. Here we're going to go over cross-sectional anatomy of this hematoma. Here you can see the hematoma within the tibialis anterior muscle. You can also appreciate the extensor hallucis longus muscle and extensor digitorum longus muscles.